My name is David Lieberman. I'm the Chief of Gastroenterology at Oregon Health and Science University. And I am honored to participate in this effort by the Centers for Disease Control and Prevention to improve the quality of colorectal cancer screening. For those of you who do not know me, I am a past president of the American Society for Gastrointestinal Endoscopy and a current member of the governing board of the American Gastroenterological Association, or the AGA. I have been a participant in the National Colorectal Cancer Roundtable for many years. I served as chair of the Multi-Society Task Force on Colorectal Cancer for 6 years and participated in the development of colorectal cancer screening and surveillance guidelines. My research has focused on colorectal cancer screening, surveillance, and quality. We now have compelling evidence that colon cancer screening works. It reduces the incidence and mortality of colorectal cancer, but only if it's performed with high quality. The topics that we're going to be covering include ensuring that colonoscopy is appropriate and indicated, that the importance of a good bowel prep and the role of split dosing, the importance of complete documentation and the role that that plays in communication with primary care physicians and patients to determine when the next exam is appropriate, and the need to improve the quality of colonoscopy and monitoring quality indicators. So let's start out talking about considerations before you perform a colonoscopy to ensure that the exam is appropriate, it's at the appropriate interval, and that the patient is medically appropriate for the procedure. The other elements to think about prior to the examination are optimizing the bowel prep and then managing any patient medications and other conditions. So is the colonoscopy exam appropriate now? And so we have recommended screening intervals based on the age and family history that we discussed in part 1. And I'll show you an example of how you can go back to the earlier slide. So for patients that are average risk, we have several screening options, but the recommendation for performing colonoscopy is at 10-year intervals if the baseline exam was a normal examination and was complete to the cecum. So you can use this method to go to additional slides, and then when you're done looking at that slide, those slides will have a go back message and just return to the primary slide show. We also discussed in part 1 the recommended surveillance intervals for patients that have had prior polyps, including those that have had prior adenomas. And I'll go to the slide that shows that, which highlights low and high risk individuals. So patients that have 1 or 2 adenomas less than 10 millimeters in their baseline examination represent a low-risk group, and they can have colonoscopy in 5 to 10 years after that baseline examination, whereas those that have 3 or more adenomas or adenomas greater than 10 millimeters or with villus features or high-grade dysplasia represent a higher risk group, and they should have colonoscopy performed at 3-year intervals. So I encourage you to use the links provided on this slide set, which enable you to move to additional slides. If the examination is going to be performed at a different interval than guidelines have recommended, we encourage you to include a reason for deviating from the recommended guidelines. And there can be many good reasons for deviating, but this should be documented in the medical record. Today, many patients are referred directly for colonoscopy in so-called direct access. And I'd like to spend a few minutes talking about the circumstances under which you should think about seeing the patient prior to the scheduling of the colonoscopy. So elderly patients have a higher risk, and elderly over 75 have a higher risk associated with colonoscopy. Patients that are getting anticoagulation or cannot safely stop their medications, patients that have had recent infections or active cardiac, renal, pulmonary, or liver disease, patients that have had a prior history of difficulty with sedation or anesthesia, patients that have had poorly prepped colons in the past. These are all situations in which you may need to take some special precautions, and you may need to take some special measures to ensure that you can perform a safe and effective colonoscopy examination. The bowel preparation is perhaps one of the most mundane topics related to colonoscopy, and it is the most important. So I want to spend a few minutes talking about the reasons this is so important. The consequences of a poor prep include difficulty actually performing the colonoscopy itself, prolonged procedure time, reduced rates of completing the exam to the cecum, the need for repeat procedures at a shortened interval, and most important, a reduced ability to detect important pathologies such as polyps or cancer. We have evidence that the bowel prep is inadequate in up to 25% of patients undergoing colonoscopy in the United States. And this is an important factor associated with the possibility of developing interval lesions after colonoscopy. There are several types of bowel prep. There are so-called isoosmotic full volume preps, and these isoosmotic preps are basically not absorbed. And so there's full volume, which is generally 4 liters, lower volume preps, and then hyperosmotic preps. The important message, though, about the prep is that the instructions need to be clear and they need to be understood by the patient. So they have to be at an appropriate literacy level. There have been many innovative approaches taken to try to improve the quality of the bowel prep, and I encourage you to look at some of these links. One is a YouTube video that talks about the preparation for colonoscopy, and then there are actual examples from several centers showing bowel prep instructions that are given to patients. We hope that these additional materials will be helpful to you in advising your patients about bowel preps. There's evidence that using patient navigators can improve both the adherence and the quality of screening examinations. So these navigators can be effective not only in communicating and helping patients navigate through the system, but they can be a way of helping communicate information about the bowel prep, which, as I said, is so critical to the performance of a high-quality exam. In many studies, there's been evidence that navigators help get patients scheduled. They help get the appropriate tests done and help with transportation, language issues, and, as I said, bowel prep and getting patients ready. So this is something to think about in your practice, and it may help with improving the effectiveness of the overall screening experience for your patients. So we have a question. What is the preferred bowel prep dosing schedule for colonoscopy? And the answer is that the split dose prep is clearly now preferred over any other method, and that applies to all of the various bowel cleansing preparations. So it's now recommended in several guidelines, and the concept here is that half of the laxative is taken on the evening prior to the examination, and the remainder is taken in the morning of the procedure. The colonoscopy can be performed 2 to 4 hours after the last dosing, and it's more effective and better tolerated than the full dose evening dosing that used to be used. In studies, it's been demonstrated to be superior for both the isoosmotic PEG high and low volume, as well as osmotic. So it really should be used for any form of PrEP that you are considering. And here's the evidence. This comes from a meta-analysis that showed that, number one, that the PrEP cleansing was better, far superior. Number two, patients were less likely to discontinue the PrEP. Number three, that patients were more willing to repeat it with the PrEP. And number four, they had fewer side effects. So if you look at this slide, this is a win-win-win-win situation, and there should be no doubt now that split-dose PrEPs should be used in practice. There are potential barriers to split-dosing PrEPs that have been raised that we believe are not significant concerns. One is patient acceptance, because this may require the patient to wake up in the middle of the night to take the second dose prior to an early morning procedure. But when patients have been surveyed, more than 85% are willing to get up in the middle of the night to take the second dose. And for those that are not, you may want to consider scheduling into an afternoon procedure. A second concern is, am I going to have difficulty during the transportation from home to the endoscopy center to have my procedure and need to make several stops along the way? And most of the evidence suggests that there's very little difference between taking the full dose in the evening or having the split dose PrEP. So it's a matter of timing and understanding how far the patient needs to go, and this is where a patient navigator may be very helpful. There is a potential risk of increased risk of aspiration during sedation because patients may still have some liquid in their stomach. However, the anesthesia guidelines do allow for ingestion of clear liquids up until 2 hours before sedation, and that is more than sufficient for patients undergoing a bowel PrEP. So most of these alleged barriers are really not a barrier to split dosing, and we strongly urge that split dosing be used in practice. For those patients that are going to have an afternoon examination, the PrEP can be given, part of it in the evening before and then part of it in the morning before the procedure, ending more than 2 hours before the scheduled colonoscopy should begin. What about diet? There are various diet regimens that have been recommended. The optimal pre-procedure diet is still really not well defined. Most experts would consider going on a clear liquid diet for 24 hours prior to the examination, or having a very light but low fiber breakfast on the day before the procedure, followed by clear liquids. The important message, I think, to patients is that they need to drink a lot during that day before the procedure, and that will help make the bowel PrEP, the laxative, much more effective. How do you predict if somebody's going to have a bad PrEP? Well, clearly, if somebody's had a bad PrEP in the past, they may be likely to have it again. But there are other patient characteristics that may help you determine that you need to do some special PrEP considerations. Patients that are in the hospital tend to be difficult to PrEP, and I think this is partly because they're not moving around very much, and they may be on medications that can slow down the gut. The elderly, the obese, patients with lower levels of education tend to have less adequate PrEPs. Patients with a history of constipation, patients that are using antidepressants, particularly those that may have an anticholinergic effect, and patients that are on chronic narcotics. Narcotics slow down the bowel and can make prepping very difficult. And then, of course, patients that are not compliant with their medications may also have difficulty with the PrEP. This is another area where having a patient navigator can help address some of these issues, but special considerations may be needed for some individuals if you can anticipate that they're going to have a bad PrEP. So how can you improve the PrEP for patients that have had a prior poor PrEP? Well, there are really no good studies, but there is evidence that the navigator and patient education work. You can increase the total volume of the laxative solution from 2 to 4 liters if it's a low dose, or 4 to 6 liters if it's a higher dose. Split dosing, as I mentioned, is very effective. Ensuring adequate hydration is absolutely important. And then potentially adding other agents such as magnesium citrate or Miralax the evening before beginning the prep, so that would be 2 days before the procedure, may help with the bowel prep. Adding bisacodyl or senna to help with evacuation can help some patients that have constipation. And then extending the period of diet modification from 24 hours to 48 hours. So these are all individual considerations that you should think about in patients where there's either a past history of poor prep or you anticipate a poor prep for the reasons that we have talked about. Other things to think about prior to the colonoscopy are special precautions. And we have a link to slides for each one of these areas. So for example, if somebody is on anticoagulants, you need to think about whether they can be safely stopped over a period of several days or whether the patient has to be bridged. For patients that are taking diabetes medications, we generally recommend that they will be taking half of their medication on that day before the procedure because they're not going to be eating any food. Antibiotic prophylaxis we rarely need to do, but there are certain circumstances. And each one of these items has a link to a slide that will take you to the established recommendations. One area where I think is very important are patients that are taking oral iron for any reason. Iron is very difficult to clear during the prep, and so we recommend that oral iron medications be stopped at least 7 to 10 days before the patient has their colonoscopy. And cardiac devices, we have a couple of slides describing the management, and you should be working closely with your cardiology colleagues to help manage some of these devices at the time of the procedure to make sure that all precautions are taken. What about sedation? Well, there are several options for sedation, including conscious sedation and deeper sedation with propofol. Propofol has become popular in the United States because it has a very rapid onset of action and a very rapid recovery. So patients sleep during the procedure and then they wake up very quickly after the procedure is completed. It's probably necessary for a small fraction of patients who cannot be effectively sedated with moderate sedation or at increased risk for sedation, for moderate sedation. So these could be individuals that have a prior history of difficulty with moderate sedation, cannot tolerate those medications, or are on chronic narcotics and therefore would be difficult to sedate with moderate sedation. The major limitation with propofol is the possibility of moving from deep sedation into general anesthesia with respiratory depression. In most states, there's a requirement that anesthesia personnel be available, and that could substantially increase the cost of the procedure. Propofol is not covered by all insurers and often only for specific indications. So what are those indications? And they can include patients that have dependence on opiates and sedatives like benzodiazepines, that have significant neuropsychiatric disorders, that have had a negative experience with prior sedation efforts, drug or alcohol abuse. The extremes of age, very young and very old patients may benefit from having careful sedation with propofol. Pregnancy, morbid obesity because of the difficulties of managing these patients with conscious sedation. And anybody that is going to be uncooperative or if the procedure is going to be complex or lengthy, at least you should think about the use of propofol. Finally, increased risk of airway obstruction should be also considered as a potential reason for considering propofol. So we're going to move on to some of the quality elements of the colonoscopy report. And so the question posed here is what elements should be documented in every report? And the quick and simple answer to this is these are elements that will be communicated to other physicians and to the patient, and will help direct the subsequent management of that individual, including the appropriate interval for the next examination. So the documentation, which seems like a fairly simple step, becomes a very important step as part of a quality practice. And we should ensure that all the key elements are noted because it facilitates communication with physicians and the patient, and also allows monitoring of performance to compare with other practices. So what are some of these elements? Well, we have tried to define these elements in a paper that we published several years ago, and the link to this paper is provided on this slide. This was designed after the development of similar reporting systems for radiology and mammography. And so it's a fairly simple system that includes key elements from the pre-procedure, intra-procedure, and post-procedure periods. And so we're going to talk about each one of those. So in the pre-procedure report elements, the endoscopist should document the informed consent, the patient demographics such as age, sex, and race, and then any appropriate measures that are needed for management of anticoagulation, cardiac devices, and diabetes, so that these elements of precaution are carefully documented in the medical record. There should be some assessment of the patient risk comorbidity. Many physicians use the anesthesia classification, which defines 5 different groups of patients, and most patients that have endoscopy will be either ASA class 1, 2, or 3. In evaluation of the airway has been recommended by our anesthesia colleagues, and then some documentation that there's been a recent history and physicals so that if there are any new medical problems, we're aware of those problems. There are several categories for the indication for the procedure. Screening refers to patients who are asymptomatic, who do not have a personal history of either adenomas or colorectal cancer. This could include patients with or without a family history of colorectal cancer or adenomas. But also include patients that are asymptomatic but have had some other positive screening tests, such as a fecal occult blood test, fecal immunochemical test, sigmoidoscopy, barium, enema, stool DNA, or CT colonography. These patients are still asymptomatic, but if those tests are positive, that is an indication for a colonoscopy. A second major category for indication would be surveillance, patients that had a prior personal history of either colorectal cancer or adenomas, and if possible, the details about when those diagnoses were made and what was found on prior examinations help guide the subsequent management for that individual. This also includes patients that have chronic ulcerative colitis and Crohn's disease, and the intervals for performing those exams should be at about every 2 years after the patients have had disease for 8 years. Finally, the diagnostic category, these are patients that have had signs or symptoms of lower GI disease that could include colorectal cancer or other diseases. And in this case, the specific signs or symptoms should be specified in the medical record. The other pre-procedure elements that should be documented would be any prior colonoscopy history and a detailed family history. And the rationale for the family history, as I mentioned, is that it could identify patients that are going to need more frequent examinations based on the age of the index family member that had cancer or high-risk polyps. If there is an indication that does not seem to fit into guidelines, or the exam is being performed before the recommended interval, this deviation from the guidelines should just be documented. There are many good reasons for deviating from guidelines, but the important message is that it should be documented in the medical record. During the procedure itself, there are certain elements that should be documented, including the bowel prep type and some assessment of bowel prep. So was the final bowel prep good enough, good or excellent, for each segment of the colon? And if not, was every effort made to try to convert a fair prep into a good prep during the withdrawal of the instrument and cleaning during the procedure? So this is an important part of the documentation of the procedure. So how to rate the bowel prep? And there have been several methods used. One is just an excellent, good, fair, and poor examination, with fair being defined as adequate to detect polyps greater than 5 millimeters after cleaning. The second method has been to simplify this by just saying it was either adequate to detect lesions greater than 5 millimeters or inadequate to detect lesions greater than 5 millimeters. There's a more rigorous method that has been developed called the Boston Bowel Prep Score. And this is a scoring system that's used after the bowel has been cleaned during the withdrawal of the instrument. The important thing about this scoring system is that it has been linked to what happens after the procedure, the development of polyps later and the development of interval cancers. And so this is a report that I think allows you to assess each segment of the colon. So you give a grading system for 3 different segments of the colon, and you can differentially assess whether you've seen all or part of the colon adequately. Finally, there should be some documentation of the extent of the exam. Ideally, there should be photo documentation of the cecum that includes the appendiceal orifice and the ileocecal valve. The photo shown here shows the ileocecal valve at the very top, or around 12 o'clock in this photograph. If you did not reach the cecum, you should document how far you got by anatomic segment. And if the cecum is not reached, a reason should be provided for not reaching the cecum. Also, there should be documentation of the sedation used, the dosage, and the withdrawal time after you've reached the cecum. The reason for documenting withdrawal time is that there has been a relationship between the withdrawal time and the adenoma detection rate. And so having an adequate withdrawal of at least 6 minutes is recommended by most experts. Finally, it's been recommended by most experts to perform retroflexion in the rectum and to document that to be able to see perianal pathology. The other elements include a description of all the findings in enough detail that a reader can understand what was found. So for example, for polyp descriptors, that would include measuring the size of the polyp or an estimate of the size of the polyp based on endoscopy, the location, and the appearance of the polyp. So this is an example of some of the descriptors that one might think about, showing an example of a pedunculated polyp, a sessile polyp, and then a very flat polyp shown on the bottom. So these descriptors should be included in the report. The method of removing polyps should also be documented so that if a snare was used, was cautery used or not, was injection used to raise a lesion, was the resection complete, did it need to be performed in several pieces, so-called piecemeal resection. Any suspicious lesion in the colon, and by this I would mean any lesion greater than 2 centimeters, should be tattooed with India ink, and so that it will be easy to go back and re-inspect that area on a subsequent examination. The only exceptions to tattoo would be if the lesion is in the cecum itself, where you have other anatomic landmarks like the appendix and the ileocecal valve, or in the rectum itself, where you know exactly where you are. The other question that should be addressed in the report is whether the polyp was actually retrieved for a pathological examination. So when we retrieve polyps, we need to give our pathologists important information about the pathology specimen. And pathologists need to know the colon description of the lesion that we removed, the morphology, whether we think it was completely removed, and what portion of the colon it was taken from. And we provide some examples here of descriptors that might be used to communicate to your pathologists. So it's important that they have as much information as we have at the time that they're examining this. There's some controversy about whether pathology specimens can be pooled into one jar. Most experts would say that if a polyp is greater than 5 millimeters, it should probably be placed in its own vial. There are situations where there's a cluster of polyps in one portion of the colon that are all diminutive, less than 5 millimeters. And some experts believe that it's reasonable to pool some of those polyps into one jar to reduce the costs of the pathology. After the procedure, it's important to provide recommendations for follow-up based on the patient's history, their age, their comorbidity, and the colonoscopic findings. In many cases, this is going to have to be delayed until after the pathology results are available and you know what type of polyp that you are dealing with. The recommendations for follow-up should be consistent with evidence-based guidelines. But if for some reason you think that the examination should be performed at a different interval, then you should provide a reason for deviating from those guidelines. Those recommendations and results should be communicated very clearly to both the patient and to the referring provider. And ideally, there should be a follow-up for any adverse events occurring after the procedure is completed. In terms of recommending appropriate follow-up, one of the issues that should appear in every report so that any reader can look at it is, was the exam complete to the cecum, was the bowel prep adequate, and were the polypectomies complete? Because if they were not, then that may be reason that there will need to be a shorter interval for the next examination. And that shorter interval would be exams that would be performed in 2 to 6 months after the procedure. In patients where the cecum was not reached, who are average risk, should those patients have yet another colonoscopy or some other examination? And the answer is not clear. These patients are still average risk, so they may benefit from having a high sensitivity guaiac FOBT or fecal immunochemical test. Many physicians would use another examination like CT colonography to view that portion of the colon that was not adequately seen. And so I think the management of these patients should be individualized. In the next slide, we discuss the appropriate follow-up for an incomplete examination. And there are several options for those patients that had an adequate bowel prep, but it just wasn't technically possible to complete the exam due to a tortuous colon or prior surgery, adhesions, or various colon diseases. The options include using a capsule that can be swallowed, the so-called PillCam colon, that allows visualization of the colon, or performing CT colonography to visualize that portion of the colon that was not adequately seen. In patients where the exam was incomplete due to ineffective sedation, that's an exam that might be repeated in the future using deeper sedation with propofol and other sedation medications. The key point is that if a high-quality exam is completed and it's negative, the patient does not need to have another exam again for 10 years if they're average risk. The next slide poses a question. In an average risk patient who has a complete colonoscopy with no findings, should you recommend an interim stool test before his or her next colonoscopy is due in 10 years? The key message here is that patients that have a negative colonoscopy who are average risk have a very low risk of developing any serious colon pathology for 10 years or more, and therefore they probably do not need any screening during that 10-year period. There is no evidence that supports the performance of an interim test, such as fecal colpoid testing or fecal immunochemical testing prior to the next colonoscopy. There are other groups where the management of these patients might be different. And so patients that have a family history with a first-degree relative who had cancer at age less than 60, those individuals should have examinations at 5-year intervals. And then we've talked earlier about patients that have adenomas, serrated polyps, or a history of colon cancer. Those patients will have examinations at shorter intervals based on the significance of the lesion that was found on their examination. What about patients that had only a fair prep at the baseline colonoscopy? Here we have little or no published guidance or evidence to guide us, and so it comes down to clinical judgment. The follow-up for these individuals should be individualized based on the patient's age, their comorbidities, and the goals of the procedure, as well as the risk. So for example, an elderly patient, it may be that the goal of that procedure is to detect important lesions. And you might be satisfied if you felt that the exam was sufficient to detect important polyps or growths in the colon, then that patient, even though the prep was fair, may not need another examination. In selected cases, it may be very appropriate to recommend that the patient return earlier than the interval recommended. And this could include younger patients who have a much longer lifespan ahead of them and may be more likely to benefit from a high-quality exam. If the exam was only fair, though, then it's worth considering whether these patients will need to have special prep instructions to assure that that next exam is really an excellent or good bowel prep. The communication with patients and referring physicians about subsequent recommendations cannot be emphasized enough. There should be clear communication about what was found and the implications of those results in terms of next steps. So a summary of the findings should be provided for both the patient and for the referring physician, and a very clear recommendation for the next examination should be included with that note to both the patient and the referring provider. After the colonoscopy, when the patient is awake, it's important to discuss the major findings of the procedure, whether it was adequate, whether polyps were removed and when those results will be available, and what to do in the following days in terms of diet, medications, driving, etc. And what to look out for, particularly any complications of a procedure such as bleeding or perforation or pain. The patient should understand with clear instructions what to do if those things were to happen. The patient should be given written discharge instructions that tell the patient what to do should any of these serious adverse events occur. If possible, capturing what happens to the patient over the next 30 days should be done. We realize that this is not feasible in many clinical practices, but it would certainly be valuable to know if patients had any serious events occur within the 30 days after they've completed a colonoscopy. Finally, this communication should occur in writing so that there's no misunderstanding of what was being found, and what is being recommended to both the patient and the referring provider. So the communication with patients should be in a written form, ideally, that provides them information about when they need to return based on their risk level. Depending on the findings, it may be important to encourage the patient to talk to their family members about the importance of these findings, because it may have implications for the family member. So for example, if the patient has colorectal cancer, they should be notifying their family members, because those family members are going to be at increased risk for colorectal cancer themselves and should be initiating screening at a younger age and more intensively. So as part of the communication with the patient, encouraging them to speak to their family about the findings is an important part of that communication. Finally, reminder systems are very important, and they work. We have very good evidence from a variety of studies that getting patients back at appropriate intervals using computerized reminder systems are very effective. But what's also effective is making sure that the patient knows when they need to come back. And because patients may leave a practice or they may leave a city and go somewhere else during a 5 or 10-year period, it's important that the patient understand when they are due for their next examination so that it's done appropriately. Moving on to the quality of colonoscopy and how to monitor quality. A few questions to think about as we discuss this section. First, are some endoscopists better than others at finding adenomas? What is the minimum adenoma detection rate that you should achieve for screening examinations in average risk individuals? And what should you do if the bowel prep quality is only fair or poor in more than 10% of your patients? So the need to improve the quality of colonoscopy has been highlighted by variation in practice. We know from a variety of studies that there is wide variation among endoscopists who are performing screening examinations in similar types of patients, where we would expect to have rather consistent results. So the variation includes the detection of polyps, the ability to reach the cecum, the quality of the bowel prep, the appropriateness of the screening and surveillance recommendations after the procedure, and the completeness of reporting. So there is room to improve quality. How can it be improved? And there are several methods, but certainly having a continuous quality improvement program within your practice will enable you to monitor performance of the endoscopists in your practice, compare with benchmarks and national targets, and then take steps to improve performance when it is needed. There are recommendations from the U.S. Multi-Society Task Force on Colorectal Cancer, as well as the National Colorectal Cancer Roundtable, about elements that should be measured. And very recently, a new publication in 2014 on the quality indicators for colonoscopy are included in the links provided on this slide set. So what should be monitored? And the highest priority items include the adenoma detection rate, the cecal intubation rate, the quality of the bowel prep, and the use of appropriate intervals after screening and surveillance is completed. And some of these have now become measures of CMS quality programs, such as the Physician Quality Reporting System, or so-called PQRS, that many of us need to provide reports to. So let's talk about the adenoma detection rate. What is it? It's really the rate of finding adenomas in average risk screening examinations. The current target that is recommended in the 2014 recommendations are that it should be greater than 30% for men who are undergoing screening examinations and greater than 20% for women undergoing screening examinations. Why is it important? it's important because it has been linked directly to the development of interval cancers in subsequent years after a colonoscopy. So perhaps the most important quality indicator would be the rate of interval cancers, which is difficult to measure. But this is an excellent surrogate marker which has been shown to have a direct relationship, so that patients that are high detectors above these targets have low rates of interval cancers in the next 3 to 5 years amongst their patients. Whereas patients that have physicians who are low detectors, their patients have higher rates of interval cancer in the 3 to 5 years after their colonoscopy is completed. That is why this is important. That is why all of us should know what our adenoma detection rate is. The targets highlighted in this slide are new targets that were just published recently in 2014 and represent the most recent data for screening examinations. What else should be monitored? Well, the cecal intubation rate represents an estimate of whether the exam is a complete exam. And if the exam is not complete, then important pathology may be missed. So it's really defined as the percentage of exams in which the cecum was reached when it was intended to reach the cecum. The target for all examinations is greater than 90%. The target for screening and surveillance examinations is greater than 95%. And again, the reason this is so important is because important lesions can be missed if the colonoscopy is not complete. How do you know if it's complete? I think that most of the guidelines and experts recommend that there be photo documentation that demonstrates at least one of these features, the ileocecal valve or the appendiceal orifice, to demonstrate completeness of the exam. Quality of the bowel prep. We've talked about quality of the bowel prep several times, and it remains one of the most important targets and one of the most important barriers to a highly effective colonoscopy. We recommend that all practices monitor the quality of their bowel prep and the adequacy with a target of achieving greater than 90%, either good, excellent, or adequate to detect lesions greater than 5 millimeters. We mentioned that a poor bowel prep results in missed lesions, a need for repeat examinations at shorter intervals, which drives up the risk to patients as well as the cost. We recommend that if a practice has less than 90% of exams that are good, that you should look very carefully at the processes that are involved in patient instructions and the type of prep you're giving. So the preps should all be split dose preps. The instructions should be very clear, and you may want to consider the use of a patient navigator to help the patient, guide the patient through this process of the bowel prep, which is so critical to a high-quality examination. Finally, the appropriateness of the screening and surveillance recommendations should also be monitored so that you have an idea of how often you're deviating from the published guidelines that are based on evidence. We know that in certain situations, the exams are performed at shorter intervals than are recommended, which has the potential for wasting resources as well as the potential for harm with little benefit. And then there are other circumstances where a procedure should be performed more often in patients with higher risk lesions or incompletely removed lesions, and those patients would be at risk for development of cancer. So adhering to evidence-based guidelines should be a quality metric, and reasons for deviating from that guideline should be provided as part of a high-quality report. The other things that should be monitored would be some of the descriptors, whether or not the reporting elements are included in the report. So does the report indicate the polyp descriptors? Is the polyp retrieval rate documented? is the rate of repeat examinations in less than a year for poor or inadequate prep documented? Are tattoos placed for large or suspicious lesions except in the cecum and rectum? So these are other parameters that can be followed as part of a high-quality colonoscopy practice. A paper was published several years ago to assist physicians in what questions that they might ask their endoscopist about the quality of their colonoscopy examinations. And so this paper is provided here as a reference for you, and the source document can be obtained to enable you to know what questions to be asking about colonoscopy quality. So a few final take-home points from this section of our discussion. First, that that we should be following evidence-based screening and surveillance guidelines to ensure that colonoscopy is performed at the appropriate time in the appropriate patient based on the personal and family history. Second, that we should be working and striving for good to excellent bowel preps in all patients. Split dose preps are strongly recommended. That every effort should be made during the examination itself to convert a fair prep into a good prep with cleaning during the procedure, even though that takes additional time during the procedure. And if the bowel prep quality is inadequate in more than 10% of patients, then it's important for practices to look at their procedures to see if they can improve their educational materials, if they can improve the navigation process for their patients. Complete colonoscopy reports are essential for clear communication with both patients and referring providers so that the appropriate next steps can be taken at the proper interval. And the quality of colonoscopy is highly variable, and therefore it's important for all of us to monitor performance with quality indicators and quality metrics, and then take steps to remediate when the benchmarks are not achieved. I want to thank all of you for viewing and participating in this course. I want to remind you that we have many resources embedded in these documents so that you can click on links that will take you to many wonderful source documents.